online in real time will still be able to access this event at a later point. So let me start by talking about how we hope that you can be more successful at using this resource in your setting, and how you can facilitate your trainers to be more successful at teaching in an interprofessional format. As I think you are all aware, the format for these modules is that all of them are taught in an interprofessional arrangement. So we hope that you will be able to bring together learners from different cadres who will sit together in the same venue in groups of 4 to 8, and with a mix of different learners in each different small group. And then you would use your trainers, your faculty, to facilitate that training. And we imagine that there would be one faculty member, one trainer, who would be overseeing several of these small groups and would be walking between them, answering questions, and as appropriate, teaching some of the content from the front of the classroom. And we've included some PowerPoint slides where there is appropriate need for didactic interaction. But the main emphasis of this training is that it's small group based, and as such will not require too much didactic teaching from the front. But a key facet of this is that it's interprofessional. Obviously, Stripe is all about strengthening interprofessional education. And I think that, part of the reason why we're emphasizing that it's interprofessional is because there is an increasing recognition that to deliver complicated healthcare in our settings demands a team-based approach in order that we're able to effectively deliver the needs of patients living with HIV. Moreover, I think an interprofessional approach to learning is something that is being advocated by most professional health bodies around the world, in particular AfriHealth, some of our affiliated institutions as well. And I think the other key thing is that we recognize that this approach to learning is ideally suited to capacitating learners with some core clinical expertise. So I think interprofessional education is well suited to improving analytical skills. And that's not just about engaging with laboratory and clinical data, but also appropriate deliberation of ethical issues. Interprofessional educational approaches are also ideally suited to strengthening leadership and management capacities for both physicians in learning, as well as nurses and pharmacists and other healthcare cadres. And then crucially, and then this is another thing that comes across through many of the modules, we think the interprofessional team-based approach to learning is an effective way of enhancing communication skills for health professionals in training. Unfortunately, I think many of you know this, that interprofessional education has been historically neglected by many healthcare educational institutions. And as you may be experiencing in your setting, there's variable commitment from senior management for IPE initiatives. And that reflects the fact that there's often lack of resources, whether it's time or interest or knowledge, as well as structural barriers. And for many in clinical practice, the idea of learning interprofessionally, feels uncomfortable. We're trained to practice and learn in our traditional silos, and I think that can be detrimental. So our hope is that this training resource that many of you are working on right now in your setting, Stripe, becomes an opportunity to overcome some of these obstacles. So I wanted just to leave you with a few key tips for ensuring that interprofessional activities in your setting are successful. And I refer you to an article that was published earlier this year, 12 tips for successful interprofessional education, the link for which I've included here, and I will share after the meeting. I'm just going to go through 6 of those 12 tips with you. So the first is, tip number 1 is start networking. and this comes not from us, but from the article itself, but I think it's very germane to the Stripe community. You know, I think one thing that we want to emphasize is the huge opportunity that exists to leverage the Stripe community, members of our own network, to enhance our learning and to share best practice. And I want to sort of recognize even from the get-go the valuable work that some of you are already involved with in your settings to advance a interprofessional education agenda. And I just kind of call out colleagues from Zimbabwe and KNUST who are really at the vanguard of thinking about innovative ideas for interprofessional education in your setting. I also just want to highlight the technical working group on interprofessional education that is led by AfriHealth, and the leadership from people like Judy Canyola and Elsie Kajulu-Mawadi, who are really advancing an interprofessional education agenda, across AfriHealth. And I definitely encourage you to connect with these people as people that are really championing interprofessional education. The second tip that I want to advocate for is focusing on the content. So Stripe, I think, affords us a unique opportunity to teach interprofessional content in our settings, and specifically, I think HIV as a context for learning interprofessionally is unique. And as all of you who are HIV clinicians know, practicing high quality HIV care demands a team-based approach, and there is an abundance of educational content that is relevant that can be used to teach on interprofessionally, and so hence this project. Tip number 3, make sure that it's interprofessional education and not just shared learning. So this is a key thing I want to highlight. Some of your schools are already doing shared learning, whereby individuals from different health professionals are learning together, but not necessarily collaborating together. So many of you are involved with giving lectures to nursing and medical students together, particularly in the preclinical setting. And that's a bit different from what we're referring to here. True interprofessional education involves partnership, participant learning from interaction with each other, and enables the development of trust and teamwork, so that these team members are able to function more effectively together. Tip number 4, timing is crucial. And what I mean there is that, the timing in the academic calendar is important. So interprofessional education too early in the life cycle of a learner may have little impact or less impact than doing it at the right later point. So students need to understand their own professional identity. They need to understand that they're a medical student or a nursing student, at the same time as understanding the need to collaborate with other cadres. I think, thinking that through and recognizing the importance of these dual roles that learners play as an individual professional as well as a member of a team are crucial to generate the greatest chance of engagement in small groups, etc. Tip number 5, management of professional identities appropriately. So interprofessional teams must collaborate whilst simultaneously maintaining discrete professional identities. And this builds off tip number 4, but learners need to understand their dual identity as a team member with specific professional skills and roles, as well as the professional boundaries that exist between groups. And finally, tip 6, seize opportunities for support. So I sort of mentioned this a little bit at the beginning, but that, in addition to the communities of practice that exist within AfriHealth, there are great resources out there, and I can share some of these with you. So HRSA itself produces the AETC, the AIDS education team interprofessional toolkit. There is also Team Steps with a set of resources for teaching interprofessional skills in the clinical setting. And then the American Association of Medical Colleges has a number of resources for interprofessional collaboration. And I'm happy to share all of those with you in my next missive after this event and when I share the webinar details. So that's enough from me. I think the key thing I want to communicate is the importance of interprofessional resources to delivering Stripe. And without further ado, please let me hand over to my colleague Cheyenne Martin, who's going to moderate the second section of this webinar.
Thank you, Mike. So for today, the first module that we're going to review, or that Dr. Simitala is going to review, is ART adherence and evaluation of urologic failure. And so I will hand it over to Fred. Dr. Simitala, can you check your volume, please?
Hello?
Great. I can hear you.
All right. Thank you, Mike, for that introduction on interprofessional education. And thank you, Cheyenne, and everybody who is online. It's a pleasure to once again talk about one of the modules that have been put across to use for this, facilitate the learning. I think every day, as many of you, one of the goals of HIV care is to have these patients with long-term viral suppression. And every day, for those of us who go to work on the wards, it's unfortunate that we find some of these people who were maybe previously doing very well, but then they show up with severe opportunist infections. Just today, I saw a couple of patients, either they have what we think is pneumocystis pneumonia or disseminated TB, and actually one of them passed on as we are trying to evaluate her this afternoon. So these are real issues that I think having people understanding to manage or prevent them is very critical in the continuum of HIV care. So for today, we are talking about adherence, a patient who has been started on ART and then ends up coming in with a detectable viral load. And as the overview, the goal of this case scenario or this module is to prepare learners to use evidence-based strategies to provide team-based care for a patient with ART non-adherence. The session will highlight respectful communication and collaborative leadership and employ reflective practice. To start this off, we have a case of Moses, who is a 27-year-old man with HIV. Moses was initiated on antiretroviral therapy 8 months earlier or ago. He returned to the clinic for a 6-month post-ART initiation routine visit. And during this visit, he had a blood sample collected for a viral load check, which is a practice in many setups that after 6 months of HIV treatment, we need to know how well the patient is doing in terms of viral suppression. So during the same visit, he had his blood drawn, and he was given medication for 1 month to allow for the viral load test to be done, and then the results to be returned back to the clinic. So his viral load results were lost for a while, for 1 month, But later it was found and showed that he had actually not suppressed his viral load, because at this stage, if you are following the WHO guidelines, would expect that the viral load is less than 1,000 copies per mil. But in standard of care, we think that at this time, with good uptake of these medicines, the viral load should actually be undetectable. So in addition to that, unfortunately, Moses, at 8 months, a month later than he was expected to come to the clinic, which is the 8th month from the time he started treatment, he has not returned for review. So the vignettes here is the roles. We have the patient, who is Moses, that are highlighted. We also have the providers, and the objectives for this. So we have the ART counselor, we have the healthcare professionals who are providing care. So in terms of objectives and what activities we are thinking about to achieve those objectives. So I'll quickly go through the objectives, and under each, as you can see in green, we have the activities that we propose that will help the learners to appreciate and achieve these objectives. So here we want the learners to list the potential causes of non-adherence, including contribution of the contextual factors. And the activities here, we think that the learners should be able to list these causes that could be patient-related, could be provider-related, and could be health system-related reasons for non-adherence.
Hey, Fred, it appears we've lost you. I lost your audio.
Do we lose him?
It sounds, let me check the participant.
Okay.
Yeah, he's stuck. Oh, no, he's still there.
Let's wait and see if Fred's able to join us again. Otherwise, I can jump in and cover the rest of the content.
Hi, Fred.
Fred, are you able to hear us?
Yes, sorry, I got dropped. I don't know what happened, but I got dropped off that call. But I was talking through the second objective. We would like the learners to demonstrate how to communicate respectfully and effectively to assess adherence and encourage patient engagement in care. As we all know, I think starting treatment is an activity, but successful treatment requires the patient to stay very long in care and with a suppressed viral load, which is a process. So here we think that the learners would use role play between the patient and the health professional. And here we think that one learner would act as a patient at one stage, but then act as the health provider in another case scenario. And that would help them to get a feel of what it might be to interact with a patient in a respectful manner. The third objective would want the learners to be able to describe an approach to management of intermittent and persistent detectable HIV viral load in persons who are receiving ART. And here we would like the activity we suggest is that the learners would break down in small groups to discuss on how to achieve an undetectable viral load in a patient who is on treatment. The fourth objective is about describing a shared decision-making approach and the roles of all the team members to address causes of non-adherence. And as Mike has mentioned, I think there is a difference between shared learning and interprofessional education. So here in role sharing, in decision-making approach, each member of the team would have to be able to explain their roles and how they think they can address the problem. So here they are going to focus on the patient, and then each one of them explains their role and demonstrates their role, or someone else in the group should be able to demonstrate the role of the other provider. For example, if I'm a doctor, am I able to demonstrate the role that I think a nurse would play or a counselor would play in helping a patient who is having a detectable viral load when we think they shouldn't be having a detectable viral load? So here we are proposing activities that include role play, and we are using the gather approach that will go through briefly, but also small group discussions on the roles of different cadres that they play in improving the patient's ART adherence. Objective 5, as you see here, in the case description, this patient's blood sample was taken off, and we see at the end that he has a viral load that is detectable. But two things happen here that maybe shouldn't have happened. One is that the patient didn't return when he was expected to return, but also that initially the providers were not able to trace the patient's viral load results until after a whole month. So we see that there are quality issues in the patient care at the facility where the patient was evaluated. And for this, we would like the trainees to use the 5 Whys tool, which I think I will go through briefly in the subsequent slides, to establish where is the problem. Is it at the facility? Is it by the providers? Is it in the lab? Or is it at the national level or wherever the viral load is done and then results sent to the facility? Next slide. So, going through the 5 Whys and using this example. So the purpose here really is the 5 Whys. We are looking at the quality improvement. So the 5 Whys is a quality improvement technique where we ask why a problem exists until a system's problem is identified. And on average, it takes 5 tries or asks until a system problem is identified. Often this is the first step before a root cause analysis can be done. And in the case that we've just discussed, we see that the patient's viral load results were lost for 1 month. And so the first question would ask, why was the patient's viral load results lost for this period of time? And the answer could be because it was not documented in the lab results book in the lab. So the next question then follows from that. Why were the lab results not documented in the lab results book? And the answer could be because the actual results was not relayed from the central testing lab in the central lab somewhere. The next question then follows on that, and we ask, why was the result not relayed? And the answer could be because the paper slip in the results with the results written on it was not printed out and mailed back to the clinic. So the next question builds on that gap and asks, why was the result not printed out? And the answer could be because there was a big backlog of results that were being processed. Then the next one builds on that. We are now at the 5th level. Why was there a big backlog of results? And the answer could be because there was not a dedicated person working on this, and there was no protocol on how to deal with the HIV results. So they got behind the schedule. So we see that there is a cascade of events that should have happened but did not happen, and that in a way led to interference with quality care for the patient. And here, someone may ask, how are the learners going to deal with all of this? Maybe they are not going to deal with all of this, but it's important that they see where the gaps could come about. And in that case scenario, we would like to emphasize what are those issues within the facility or within the group where the individuals work that they could deal with to avoid this kind of quality gaps. For example, it took a whole month for them to get the results. Could it have taken a shorter period, maybe if they had required earlier? So those are the whys that could help us identify where the problem is within the system, and more importantly, be able to address it and maybe prevent it from happening in the future. Next slide, please. Thank you. So there are some questions there that I could ask and try to shed some light on. And one of them is that, and I'll try to be quick on this, one of them is, what learning methods are we employing? And as you see from the way we are trying to address the objectives, some of the methods that we are using are discussions, where the trainees are allowed to discuss, but also individually come up. For example, the first question, why could someone come with a detectable viral load? It could be individual, it could be systems, but we want them to highlight, discuss, highlight where the key gaps might be, and come up with the discussions on the causes of non-adherence. But there are also role plays where the learners actually put on the shoes of a patient, but also the provider in an interchangeable fashion, so that one of the learners is at some point acting as the patient, but at the other time they're acting as the provider. And that helps them to see, is the provider approaching them well, or they are castigating them for being a bad patient, as we sometimes hear the patients who are not succeeding in controlling their viral load referred to in the clinic. So the key, but also we are using the quality improvement tools. And in this case, we have emphasized the 5 whys, which would help us to get to the bottom, the bottom of why these gaps exist. The second question is, what is the core content that we are trying to communicate? And you could answer this in many ways, but what we are thinking about here is, this is one of the case scenarios where we want to really see interprofessional care at play, or interprofessional education. And we see that in this, unless the patient is put at the center of the discussion and each of the individuals brings out what their capabilities or what their, they bring on table to bring out to improve the patient care, it's going to be very difficult to control the viral load in this patient who is failing just after 6 months of treatment. So the core content here is that how do you deal with the patient in an interprofessional way to help them recognize the problem of viral load, of virologic failure when they are on antiretroviral therapy. The next one is, what are the essential interprofessional tools that we are deploying? And here we are using the GATHER strategy. And those of you are able to look at the case, it's explained in details. But in summary, we are looking at you asking the patient, asking what the issue might be, what the patient thinks about his elevated viral load, and then you will, there is a tell there. So you tell the patient about the available services, and these could be support services and support groups, and that they could reach the providers in different ways to work with them. That's if they appreciate that it's a good, it's part of good care for them to suppress their viral load. But there's also help there, helping the patient to prioritize. Many of our patients actually have a lot of issues that are going on at the same time. And sometimes actually you find that maybe maintaining a suppressed viral load ceases to be a priority because of other issues, maybe childcare, maybe job-related issues. But we need to help them to prioritize the issues of suppressing their viral load, because eventually it is going to catch up with them and they may not be able to deal with the other issues that might be prioritizing at that time. And then we need to explain. Sometimes when we give these patients these medications, we know that the medicines work very well, but maybe they may not be aware that this is actually true. So we need to explain that we think the treatment will be effective and that they need to take it, and that if they take it, it is not only good for themselves, but maybe also good for their families. And we can bring out the concept of undetectable viral loads equals untransmissible HIV. And then we need to include a return date here, where we can, the return date for the next evaluation, but also we may be able to refer the patient to other providers and to be able to reevaluate when they return to care. So that depends on what you want to focus on. And of course here, we need to bring out to the learners the need for a shared decision making, because if we just instruct patients what to do, we are unlikely to succeed. On the other hand, if we involve them in identifying where the problem is and also work with them to see what the solution might be, that is very helpful. But also, we need to leverage the space on the strengths of each of the providers in the team. We see here that the pharmacist will have a role, the counselor would have a role, the nurse will have a role, maybe even the peer, the people living with HIV within our group would have a role to play. And we want to leverage on all these to provide a more comprehensive patient care. We have talked about the 5 whys, and we think that this is a quality improvement technique that can be used to get to the bottom of the problem and also help us to identify how we can be able to address the identified problem. Thank you very much.
Thank you, Fred. That was great. So now we will move to Module 10, which Dr. Chilembe will review. And Module 10 is on end-of-life care in a patient with HIV.
Thank you very much, Chair.
Thank you.
And good afternoon. Good afternoon, everybody. Welcome aboard Quality Improvement. Now we'll be talking about the end-of-life care, which is critical if we are to talk about interprofessional education. End-of-life care is critical because death is a reality, just like birth. And we need to have competencies and skills in handling people who are at the end of their lives. So basically, the goal of this module is to ensure that we introduce our learners to practice breaking bad news and to provide compassionate, person-centered, team-based care for patients with HIV who are having severe life-threatening diseases. And the focus basically is to ensure that the learners or the participants use reflective practice, reflective learning, where they'll be exploring again on the ethical dimensions, which are very critical again in providing critical care, because we want people to appreciate the quality of care that they are getting. And at the same time, people should be sensitive enough to instill hope to those people who are facing death in a compassionate way. So we have a case here of Isaac, who is a 27-year-old man admitted to a district hospital in a medical ward with advanced Kaposi sarcoma. All the laboratory results show diminished levels. And then we have a provider, a patient, and a patient's spouse. Here we're going to use a role play. Role play as a teaching or learning strategy is very critical again in issues of breaking bad news, because we want our learners to be active learners, and at the same time, we want them to master the skills in handling sensitive information. May you change the slide? So there are set objectives and activities that facilitators, when we start implementing the project, we need to ensure that indeed, when we have our participants who are going to comprise a diverse population of healthcare professionals, that's pharmacists, nurses, doctors, clinicians, radiographers, where they'll be available. We need to outline specifically each objective and each activity. So in end of life, we want our participants to reflect on their feelings about end of life. And because we are going to use role plays, we'll ensure that we put them in pairs and they will share their experiences in patients who are dying. And there, we also expect them to demonstrate how to break bad news to a patient and their families. They will have to practice the 6-step protocol for breaking bad news. There's a handout in the module that the facilitators will give to the participants, and they have to ensure that they know which are the critical areas that they have to attend to. Then the third objective is to discuss the preferences of that patients or families prefer in their caring. So here again, we'll be discussing the transitioning of a patient who has been critically sick, and now we know that we have tried everything, we have tried the medications, but this patient's life is going to come to an end. There again, we want the students, the participants, to observe what are the preferences in this situation. The patient and the family, do they want to take their patients home? Do they want their patients to suffer in hospital? Do they want specific interventions? So it's very critical when we are handling patients, when we are handling patients who are sick from HIV/AIDS and those optimistic infections, we have a duty to ensure that we guide them properly on what is ideal and what can we do in the case of caring for these people. Again, describing ways to promote comfort caring for a patient at the end of their life. Very, very critical. Death is just normal like birth, but we need to promote comfort. And in team-based care, each and every provider has a critical role to play. So here, we expect that they will discuss options as to what is it that patients will be given at the end of their lives, discuss the roles of each cadre, and of course, it will be very critical again to discuss the spiritual aspects. We have different ways of looking at the spiritual life. So depending, when you ask your patients as to what is your religion, depending on how you know about their religion, you can support them. You can even ask the clergy if they want somebody to come and visit and pray for, give them a last sacrament. We have a duty. And because we are saying we are going to use team-based care, this everybody has to know at what stage could they help when the patient is about to die. The last objective is discuss how to support and guide the family throughout the dying process. Death is a process and it has stages. We need to support the patient, we need to support the family. And in team-based care, interprofessional education, we need to emphasize this. So each cadre will have a role. They will read from the handouts that we have attached in our module, and they will have to say what is it that each of them has to contribute. And of course, we would love to promote reflection. Reflection is the critical thing in end of life. What is it that can make a difference if I was in this situation? If it was my relative, what is it that I would qualify to be quality? Because the issue is promoting quality of care at the end of life in HIV care. Next slide. There are 6 steps for breaking bad news, and we have attached again a handout. As facilitators, when we put our students into small groups, we prefer 4 or 5 participants. Then you provide enough room where everybody else will be free. And firstly, there will be a role play. They choose each other who is going to be the patient, who is going to be the clinician, who is going to be the pharmacist, and then you give them a chance after they have read the steps of breaking bad news. And then in the course of doing this role play, we need to check that they first have to ensure that they find out from the patient how much does the patient know about their illnesses. Are they aware that they are facing death? Then they have also to know how to share information. You don't just go to the guardian or to the relatives, this is what is happening. No. There are protocols, there are procedures, and this has to be learned when we are facilitating this module. These people whom we are going to inform about their approaching death, they will respond to the information. The families, again, they have feelings. It's our duty to ensure that we support them. That's why I was saying spiritual care, very critical. I don't know, we are coming from different settings, so we have to be culturally sensitive again when we are promoting spiritual care, when we are promoting comfort to a dying patient. And then, because I say the death is a process, the patient will not just die there and then. We need to plan and follow through the processes. We support them until when it is confirmed that the patient has died. The next slide. There are key questions which should guide us as the facilitators. Learning methods, very critical. End of life, very sensitive. So the learning methods basically that we should advance here is reflection, role play, and discussions. When we are going through the processes, firstly, our students should be helped to reflect. And the facilitators should have skills in facilitating role plays. Critical issues, ethical issues, we need to discuss them. We need to come up with questions that will help our students to reflect. So basically here we'll be advancing 3 learning methods: reflection, role play, and discussions. Core content, it's breaking bad news, supporting a dying patient, supporting families, ethical dimensions of death and dying, and family support. This is the content that we have to ensure we know it inside out, so that when they are practicing, we help them by asking them if they have indeed understood what it means. There are essential interprofessional education tools that can be deployed. Role clarification, we said this is team-based. Who is going to do what? The issue is to have to promote comfort. We have to support. Everybody who is a healthcare professional has to know that they have a role in promoting comfort, in promoting support, and guiding quality improvement methods or domains which we are supposed to advance here. Currently, we would say no, but we need to encourage reflective practice to promote compassionate care, which can help us to achieve quality life of patients who are suffering from HIV and their families who are at the end of their lives. We have a duty and we have to do it. Next slide.
That was wonderful. Thanks. I'd actually wanted to ask you about how a facilitator incorporates religion and different faiths that students might have, but I think you did that beautifully, so thank you. And we are nearing the hour, and I don't see any other questions except to ask about when the final modules will be available. We're hoping to get the version 2.0 modules out in the 3rd week of September, and this version will be based on immediate feedback that we've received from the trainers and from the program management reviewing the modules. So we're excited to get that out, and then they'll be released through our Strike website, which will also go live, and we're excited about. So with no other questions, we will close today. Next Tuesday, we will meet at the same time for modules 11 and 12. Module 11 is on PEP, and